RTOG 0915 is a randomized phase 2 trial, and this trial is looking at patients that are medically inoperable, that have stage 1 non-small cell lung cancer, and it's randomizing these patients to either a single fraction of radiation of 34 gray, so one treatment, or 4 treatments of 12 gray each for a total dose of 48 gray in daily consecutive fractions. I had alluded to this earlier about an open question of whether we should be treating peripheral versus non-peripheral or central disease differently. And this is a schema that defines the peripheral disease versus the central disease. If you look at patients that have central located lung cancer, meaning within 2 centimeters of one of the major airways, either the main bronchus or the right or left bronchus, what we observed retrospectively is that when we do the high-dose radiation, those patients are more prone to injury. So typically in most centers, these patients that fall within this cloud don't get the 20 gray times 3. They either get 4 fractions or they don't get SBRT at all. The RTOG is trying to study specifically what we should do for these central tumors. This particular study is looking at delivering 5 fractions of radiotherapy, and it's delivering incrementally higher doses to these lesions in the center of the chest to try to figure out what is the maximum dose that we can do to sterilize these tumors and avoid causing airway damage. So we should have a better understanding of how to treat central airway-located tumors in the near future. One of the questions that always comes up when we start talking about SBRT is, are we ready to start to move this particular technology and this particular treatment to patients that have curable early-stage lung cancer? And by curable, I mean they're medically operable, so they could actually have the gold standard surgical removal. So this is a paper that was published in 2011 that had patients that were candidates for an operation, 87 patients with stage 1 disease. They were treated in Japan, and the 5-year overall survival for stage 1A disease was 72%, and the 5-year overall survival for stage 1B disease was 62%, suggesting that SBRT could be a reasonable approach for even the operable patients. If you look at cost-effectiveness data in the operable patients, you'll find that SBRT is less costly than surgery for high-risk patients. It's about $15,000 for surgery versus a little less than $14,000 for SBRT. Surgery might be considered an appropriate form of cost-effectiveness if the patients that go through surgery end up having a longer survival. So what we need to do is follow these patients with SBRT for a longer period of time to either demonstrate or not demonstrate that the durability of local control and survival is the same as surgery. RTOG 0618 is a study that's opening in this country to try to ask the question of, can we safely deliver SBRT for patients that could have a surgery? So these are patients that undergo stereotactic body radiosurgery. They are candidates for surgery, and they ultimately get followed with CT scan. And if there's evidence of progression, and you can prove progression, then they would actually go on to get surgery. So it's a very interesting and safe way of trying to test SBRT in patients that are candidates for surgery. In Japan, they're opening a multi-center prospective trial that will include patients that are operable into the SBRT arm. This is another trial that's open here, and it's got a very interesting design because classically randomized trials are where you get the best data. One of the challenges with randomized trials is that the patients have to agree to participate in a trial where they don't control the type of treatment that they're going to get. So in this particular case, the randomization for early-stage disease is CyberKnife radiosurgery or an open surgery. If they get randomized to the CyberKnife arm, they end up with either 4 fractions or 3 fractions, depending on where the location is. And if they go to the surgery side, they can either have an open surgery or a VATS lobectomy for their disease. RTOG 1021 is another study looking at whether SBRT has a role. And in this particular group of patients, it's the group of patients that are candidates for a surgery but not candidates for a lobectomy. So they're candidates for something smaller than a lobectomy. Generally, we call this a wedge resection. So this will be comparing a sublobar or wedge resection to SBRT. So as you can see from these studies that are ongoing, we're going to be testing this concept of SBRT in a healthier and healthier group of patients going forward. It's going to be very interesting to see whether the data that we've seen in the medically inoperable will hold up in this population as well.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.